Welcome back to the deep dive. Today we are undertaking a micro-level exploration of the most mythologized organ in the human body, the heart.
Right.
But we aren't talking poetry here. We are talking high-performance engineering.
That's absolutely right. When you really look at the sources, these highly technical anatomy texts we gathered, they just immediately shatter that simple image of the heart as a basic pump.
So it's not just a pump.
No, not at all. What we're really dealing with is a dimensionally precise four-chambered machine that is, it's built for continuous high-pressure operation.
Our mission then is to zoom past the basics and really explore the heart's literal coordinates, its precise architecture, and the astounding measurements that define its function. We want to know exactly what makes this organ a marvel of biological engineering.
A good place to start is just, where is it?
Exactly. Let's start with the basics of location, because its placement is so strategic.
Absolutely. The heart is not just floating around in there. It is strategically placed within the thoracic cavity, and it occupies that central compartment we call the mediastinum.
Which puts it right between the lungs.
Exactly. It positions it firmly in that intermediate region between the two lung fields. And, while it's often shown as being perfectly central, it's actually slightly tilted.
It needs room to move.
It needs that room for movement during contraction.
And it's not just some kind of amorphous muscle mass, is it? The
Mhm.
sources give it a very, very defined geometry.
Oh, they do. It's described as a firm, reddish organ shaped distinctly like a triangular pyramid that's kind of resting on its base.
The pyramid.
A pyramid. And speaking of tangible facts, let's talk size.
Hmm?
The average adult heart weighs around 270 grams for men and just a little less, maybe 260 grams for women.
So it's a powerful engine that comfortably fits in your hand.
Pretty much, yeah.
What I found truly fascinating, one of the first, aha moments for me, is that the heart is physically customized to the individual's torso.
Precisely. The direction of the heart's major axis, its overall tilt, is highly adaptive.
It adapts. How so?
Well, if an individual has a narrow chest, a narrow thorax, the axis is oriented closer to vertical.
And for a broader person,
Conversely, if you have a larger, broader, or what they call a transverse thorax, the axis leans closer to horizontal.
so the body is actually optimizing its internal plumbing based on the available space.
It seems to be, yes.
Okay, so let's use that pyramid description to explore the external layout. If it's a pyramid, it must have distinct faces and boundaries. Walk us through how anatomists map the outside of the heart.
Okay, so we define three main external faces. We have the anterior face, also called the sternocostal face, which is directed forward, a bit to the right and slightly upward.
And that's sitting right behind the ribs.
Right behind the sternum and ribs, exactly. Below that is the inferior face, or the diaphragmatic face, which rests directly on the diaphragm.
Okay.
And finally, there's the left lateral face.
Now, when we talk about borders, the sources make a point of saying they're structurally different. Why would one border be sharp and another one be rounded?
That structural difference, it relates directly to the hemodynamics and the surrounding organs. The heart has three borders.
Okay.
The right border is described as being sharp, but the left border is notably more rounded.
And that's because the left side is the high-pressure side.
That's the thinking, yes.
Oh.
The right side is a lower pressure system, and this sharp right border helps define the edge as it rests near the right lung. The left side, needing more muscle, naturally presents a rounded, more robust profile.
Got it. And the base, which is the opposite of the tip, is not actually the bottom of the heart, is it?
No, and that trips people up all the time. The base, structurally, is formed primarily by the atria, the receiving chambers. It's directed obliquely backward and to the right.
Which is where all the big vessels connect.
That's where the great vessels, the vena cavae, and the pulmonary veins all enter.
Okay, then we have the tip, the apex. The sources call it the summit du cœur. But it's not a single point, is it? It's more of an intersection.
Yeah, that's a classic anatomical subtlety. The apex is divided by a really faint groove connecting the posterior interventricular sulcus. And contrary to what you might assume,
I was going to guess the left ventricle.
right, everyone does, the smaller left portion does belong to the mighty left ventricle, but the larger, more substantial right portion of the tip actually belongs to the right ventricle.
Wow. So the right side, the lower pressure system, is actually responsible for defining more of the heart's visible point. That is counterintuitive.
It is. It speaks to the unique sort of wraparound architecture of the ventricles as they converge toward the apex.
Okay, let's go inside. The central premise of the heart is separation. A venous right side and an arterial left side, which have to remain completely independent.
maintained by these incredibly strong walls we call septa. Correct. So let's examine the wall separating the two main pumping chambers. The interventricular septum, or IVS, it's triangular and built for extremely high stress, but it has two incredibly distinct parts.
And the functional contrast between these two parts is what I want to focus on. We have the bulk of it, this muscular part, and then a very thin, almost fragile-sounding portion.
Right. The primary structure is the thick muscular part, averaging a robust 1 centimeter in thickness.
A centimeter thick.
Yes. Think of that as the main pressure wall. This wall has to withstand the massive force from the left ventricle, but right next to it, forming a small cap, is the thin membranous part.
And how thin are we talking?
This part is tiny, only 7 to 8 millimeters long, and critically less than 2 millimeters thick.
Less than 2 millimeters. It's like having a 6-inch concrete wall separated by a pane of glass. The engineering difference is just staggering.
It really is.
Okay, moving up, we find the delicate wall separating the upper chambers, the intraatrial septum, or IAS. This structure is relevant to almost everyone, as it holds a vestige of our fetal circulation.
That's right. The delicate IAS structure features a depression on the right side known as the fossa ovalis, the oval depression.
The remnant of the hole we all had before we were born.
Exactly, the remnant of the foramen oval, the opening that bypassed the lungs when we were in the womb. It's bordered by a distinct crescent-shaped ridge, the limb de la fosse ovale. The depression itself is usually 3 to 6 millimeters deep.
And doesn't always seal perfectly, does it?
No, what's functionally important is that this fetal structure often remains partially open in adults, a condition known as a patent foramen ovale, or PFO.
Right.
Because the tissue flap on the left side, the valve du foramen ovale, often remains just a vestige. It seals functionally, but anatomically, it's a constant reminder of our origins.
Before blood even gets into the right atrium, the entry points themselves signal different priorities. You have the superior vena cava, the SVC, and the inferior vena cava, the IVC. Their sizes are wildly different.
And this raises an important question about the volume and speed of blood return. The SVC ostium, the entrance, measures about 20 millimeters in diameter. Okay. However, the IVC ostium is substantially larger, clocking in at around 30 millimeters in diameter.
That's a 50% increase in diameter. Why the huge difference?
It's likely a function of volume, gravity, and the total vascular bed the IVC has to serve the entire lower body and all the abdominal organs. It just has to accommodate a significantly higher volume flow rate.
And the IVC also has a valve.
A little one, yes. The larger IVC opening also includes a semilunar fold, the valve de la veine cave inférieure, sometimes called the Cuvillier valve, though its functional significance in adults is often debated.
Let's transition into the powerhouse chambers, the ventricles. The right ventricle has to send blood only to the lungs, a low-pressure short circuit. How does its internal design reflect that lower pressure job?
Well, the right ventricle maintains that triangular pyramidal shape internally, and it's neatly divided into two functional areas.
Two zones.
Two zones. First, the venous inflow region, where blood enters from the atrium. Second, the arterial outflow region, which is structurally fascinating. It's often called the infundibulum.
The infundibulum.
Or the arterial cone. Think of it as a funnel or an acceleration ramp leading directly to the pulmonary trunk ostium.
And the circumference of that pulmonary outflow ostium, the main gate to the lungs. It must be pretty big to handle all that blood.
It is substantial. It measures about 65 to 70 millimeters in circumference. This accommodates that massive but relatively gentle push of blood volume into the pulmonary circuit.
Now, inside the right ventricle, there's a muscular detail that seems key to both structural integrity and electrical timing.
Yes, the trabecula septomarginale, the septomarginal band.
Right.
This is a crucial muscular structure that bridges the cavity, connecting the anterior ventricular wall directly to the septum. It's like a structural tie beam.
But it's more than just a support beam, isn't it?
Oh, yes. Critically, it often carries a specific part of the conduction system. It's like a dedicated electrical shortcut cable running across the chamber.
So it's both structural and electrical.
Okay.
The tricuspid valve controls inflow to the right ventricle. Given it's in a low-pressure system, is it surprisingly large?
It is the largest of all the heart valves. It really emphasizes the volume demands of the right side.
And big.
Its circumference measures about 120 millimeters in men and 105 millimeters in women. It relies on 3 sets of leaflets, anchored by those incredibly strong cords, the chordae tendineae, which are pulled taut by the papillary muscles.
Okay, so now we cross the septum to the left ventricle. Everyone knows this is the muscle that defines our endurance, and the anatomy immediately confirms that.
Oh, the anatomy tells the full story of pressure. The walls of the left ventricle are significantly thicker, averaging a consistent 1 centimeter, sometimes even more.
Just to handle that systemic pressure.
Exactly. It reflects the need to generate that immense pressure. Interestingly, the walls are often smoother near the aortic outflow ostium, almost to streamline the path for high-velocity blood ejection.
And yet, despite the extreme pressures the left side manages, the mitral valve, the left atrioventricular valve, is actually smaller than the right-sided tricuspid.
It is slightly smaller. It seems the left side is optimized for pressure, not just volume. The mitral valve, which usually has two main cusps, measures around 110 millimeters in men and 90 in women.
That size difference really underscores the functional difference between the two sides of the heart.
It really does.
Finally, the exit gates. The aortic and pulmonary valves, these are the semilunar valves, and they have to slam shut perfectly against immense backflow pressure. What design detail ensures that seal?
They're thin, membranous folds, but the key is the central reinforcement. Each semilunar valve features a small central fibrous nodule on its free border, known as the nodule des valves semilunaires.
A tiny little nodule.
A tiny nodule, and it is absolutely vital. It ensures that when the three cusps meet in the center, there is a perfect sealed coaptation,
Preventing any backflow.
preventing even a single drop of high-pressure blood from flowing backward.
That level of microscopic precision is astounding. Okay, let's move from the actively pumping structures to the framework that makes it all possible, the literal foundation of a heart,
The support system.
and the non-negotiable electrical command network.
Right. No high-pressure pump can function without a stable frame. The heart's foundation is its fibrous skeleton, or what the sources call the charpente fibreuse.
And this isn't just connective tissue, it's a real structure.
Oh, it's a dense structure composed of 4 fibrous rings surrounding the 4 ostia, the valve openings.
So this is the rigid chassis upon which the entire muscular organ is built.
Exactly. These rings are fundamental anchors. They serve as the rigid points of insertion for virtually all the heart muscle fibers, ensuring that when the myocardium contracts, it's pulling against a stable, non-stretching frame.
And they anchor the valve.
They anchor the valve leaflets securely, yes.
This rigid framework provides the platform, but the whole system relies on split-second electrical choreography. Outline that specialized command network for us.
Right, the conduction system.
Yeah.
This highly specialized system coordinates contractions seamlessly. It starts with the primary pacemaker, the sinus atrial nodule, or the Keith and Flack nodule,
The master clock.
the master timing clock, generating the initial impulse. From there, it travels across the atria, coordinating their contraction, before reaching the crucial gateway,
The delay
the
mechanism.
delay mechanism, the atrioventricular nodule, or Aschoff and Towar's nodule. It holds the signal for a fraction of a second.
Why? What's the point of the delay?
It's to make sure the ventricles have completely filled with blood before they're told to fire. It separates the atrial and ventricular contractions.
Preventing them from beating at the same time.
Precisely. From there, the signal rushes down the high-speed wiring harness, the atrioventricular bundle, known as the His bundle.
And that has to get through that tough fibrous skeleton we just talked about.
It pierces right through it and immediately divides into the left and right branches, distributing the signal deep into the ventricular muscle to coordinate that powerful, simultaneous ejection of blood.
A pump needs constant refueling. We have to discuss the heart's own blood supply.
Yeah.
The coronary circulation. Where do these vital arteries come from?
They originate right at the very root of the systemic circulation, just above the semilunar valves of the aorta. So as soon as the left ventricle ejects blood, a fraction of it immediately feeds back into these arteries to supply the muscle.
What stands out, though, is the incredible protective redundancy built into that supply system.
This is a truly remarkable statistic. It speaks to the evolutionary priority of cardiac function. The right and left coronary arteries create protective connections, or anastomoses, with each other in an astonishing 97% of cases.
97%. So for nearly every single person, if one small section of one coronary artery becomes blocked, there's an immediate or potential backup route.
Exactly. It's a vital safety measure. In that small percentage where those connections are poorly developed, a blockage can be instantly catastrophic. That high percentage of redundancy is literally a survival guarantee.
Okay, so once that oxygen is delivered, the deoxygenated blood needs drainage. What's the primary pathway back to the right atrium?
The main drainage vessel is the great cardiac vein. It runs along the front side of the heart, specifically in the anterior interventricular sulcus, and it terminates in a much larger collection point.
The coronary
The
sinus.
coronary sinus, exactly. And the sinus itself is a structurally significant landmark. It's essentially a widened segment, a reservoir about 3 centimeters long, located on the posterior aspect of the heart just before it empties into the right atrium.
Completing the cycle of self-supply.
Yes.
We've covered the muscle, the framework, the plumbing. Now for the outermost layer, the protective, lubricating shell, the pericardium.
The entire heart is wrapped in a fibrous serous envelope called the pericardium. It's a multi-layered bag.
So there's an outer layer and an inner layer.
Right. The exterior is the thick, tough, fibrous pericardium, and inside that is the slippery serous pericardium, which forms a virtual fluid-filled cavity, allowing the heart to beat friction-free.
This envelope can't be free-floating. It must be anchored to surrounding structures to keep the heart stable. So how is it tethered down?
It's held securely by a number of major ligaments. Below, we have the phreno-pericardial ligaments connecting it to the diaphragm.
Okay.
In front, the sternopericardial ligaments connect it to the sternum. And behind, we find the vertebropericardial ligaments. These are crucial to ensuring the heart's position remains stable during breathing and body movement.
And because of the way the serous layers fold around the great vessels, they create these interesting hidden recesses called the pericardial sinuses.
Yes, the two key recesses are the transverse sinus and the oblique sinus. The transverse sinus sits like a sleeve, limited by the aorta and pulmonary trunk in front, and the SVC and atria behind.
And surgeons use these spaces, right?
Oh, yes.
Oh,
Clinically, surgeons use these spaces to loop around and isolate the great vessels during procedures. The oblique sinus is a deeper pocket situated right behind the left atrium.
and finally, what provides that friction management, allowing the heart to beat over 100,000 times a day without self-destructing?
That would be the aperiocerogrisso, which we can just call the serofatty apparatus.
The fatty apparatus.
Yes. It consists of fatty fringes fixed to the fibrous pericardium. These fatty deposits fill the empty spaces and, along with the serous fluid, facilitate the heart's necessary free movement within the cavity. It's just a soft, protective buffer.
This deep dive has really given us insight into the unbelievable precision of cardiac engineering. I mean, we know the pressure wall of the muscular septum is 1 centimeter thick, contrasted with that fragile membranous part less than 2 millimeters.
We understand why the IVC ostium is 10 millimeters larger than the SVC.
And we recognize that 97% safety net built into our coronary arteries.
And if we connect this to the bigger picture, it just tells us that every single structural detail, down to the tiny central nodule on a valve leaflet, is non-negotiable for stability and function.
It's all there for a reason.
The heart is dynamically calibrated, balancing immense force generation with microscopic precision.
And that brings us back to the most provocative question raised by these detailed sources. We talked about the Charpent fibrous, the fibrous skeleton, this thick, rigid, interconnected foundation, a literal rock designed to anchor massive contractile forces.
Indeed, it's the most rigid part of the heart.
Yet, nature chose to run the most fragile and essential network, the specialized electrical command pathways, his bundle and its branches, directly through that seemingly impenetrable fibrous skeleton.
Right through the rock.
Why? Why did evolution place the delicate, life-defining electrical timing system right inside the rock-solid high-stress foundation? What does this incredibly precise architectural choice tell you about the fundamental, non-negotiable importance of electrical timing in continuous circulation?
Something to think about.
Something worth contemplating long after this deep dive is over.